for access to mental health care. Today, we're here to raise expectations for competent care and to talk about how the scarcity of culturally competent healthcare dramatically compounds access challenges for Coloradans who find that they're not well served by many care providers, even when they are able to get an appointment. What is culturally competent healthcare? Well, we're going to hear about that. In short, culturally competent care is care that begins with the care provider's experience and skill in relating to, communicating with, and meeting the unique needs of the individual being served. A provider's license to practice, unfortunately, provides no assurance of this kind of fundamental competence. Consequently, many Coloradans receive poor quality care if they are able to access care at all, or they are repelled by their experience of care and no longer seek to engage the support that may be vital to their enhanced well-being. As you reflect back on your own experiences of accessing healthcare, you may be able to identify instances where you may have gotten access to some kind of care, but didn't really feel heard, seen, or understood by the provider. Maybe you were treated rudely or insultingly or condescendingly. Maybe due to different primary languages or dramatically different backgrounds, you couldn't be sure that effective communication was taking place at all. Maybe your view of health and well-being was in conflict with the provider's approach. Each of these failures exemplifies incompetent care. Cultural competence is essential for empathy and communication, indispensable to quality care, and all too rare, especially for Coloradans who have historically been underserved or marginalized. We'll be hearing more about all of this from our participants today. The state of health in Colorado, especially among our youngest and most vulnerable, is alarming. Universal, timely access to affordable and competent care is what we envision at Mental Health Colorado, but we have a long way yet to go. What we can and must all do as we continue to wait and advocate for a transformed system of care, supports, and services is take small steps each and every day to support our own and each other's well-being. To mobilize all Coloradans on their own behalf, last year we launched the What's Your Peace campaign. By sharing our daily well-being practices with one another, we reinforce our own commitment to making time in the day for the things that keep us well and enrich each other's toolkits. In a state where it's so difficult to access culturally competent professional care, the urgency of self-care, providing peer support for one another, and joining our brainwave network of grassroots advocates can't be overstated. Emma will put links to the What's Your Peace campaign into our brainwave in the chat. Your voice, your stories, your peace. By sharing them with us, you're making healthier minds across the lifespan for all Coloradans. With that, I want to acknowledge the sponsors of today's event. I want to thank Alkermes, Otsuka, and Healthier Colorado. I especially want to thank our elite sponsor of the year, Rocky Mountain Health Plans. And I want to thank all of you for donating to the best of your ability when you registered for the event or while you're here with us today. We wholly depend on the generosity of Coloradans to be able to persist with our advocacy work. And with that, I'm going to turn things over to our host for the hour, Jordan Chavez. Many of you will recognize Jordan from 9 News, where he's brought mental health to the forefront since joining the station in 2017. Jordan has also shared his own mental health journey with viewers, and he is a great ally of the organization and of our mission to achieve healthier minds across the lifespan for all Coloradans. We're so grateful, Jordan, to have you with us again for this year's lead. Welcome.
And I'm so grateful to be with you, Vincent. Thank you so much. I very much appreciate it. You know, it's funny, whenever I get asked to introduce myself, I always get asked why mental health means so much to me. How did I get here? And I always say it's because I suffer severe anxiety, which is true. But the truth is, as I sat down to really think about it this time around, I didn't get to pick my passion when it came to mental health. My interest in learning more about mental health began as and continues to be truly a fight for my survival every single day. I believe that is why so many of us are here today. If not the fact that we know what it personally feels like to feel powerless to anxiety, depression, bipolar disorder, the list goes on. then we know and love someone who also struggles with this. It reaches every single one of us. The sad part is that we have all been brought here together under this really unfortunate circumstance, but we have also all been united here with our collective hope that we can do something about this, that we can help ourselves and that we can help others manage and navigate our mental health. That the very thing that used to cripple us, that kept us, made it hard for us to get out of bed in the morning, made it hard for us to put one foot in front of the other, is now a tool that we get to create and harness a better world for all of us here. So it is a privilege truly to be back and discussing something that is so crucial to us here in Colorado and to everybody across the US and around the globe. So thanks for having me back here. I very much appreciate it. I will say that we have an incredibly packed program and we are excited. So we're just going to jump right into it. But before we do get started, I wanted to let you know that we encourage you to send all and any of the questions that you may have throughout the program this afternoon, that you can send those in the Zoom chat through the program. And we're going to turn to those a little bit later in the hour, at which point then our speakers can respond to the different questions that you may have. With that, honoring us with their presence today is our lovely group of panelists. They are the experts by experience who will discuss the gaps in Colorado's health system and the solutions that are needed to ensure the high quality, competent care and that is accessible to everybody here across the board. We begin with Katira Am. Katira immigrated to the United States in 2017, joined Spring Institute in August of 2018, and is a full-time early childhood education policy advocate. Katira strives to improve the lives of dual language learner children and families by influencing legislators and policymakers' opinions as well as their activities. Katira, thanks for being with us. We also have Brad Barfield. Brad is the vice president of Envision U, and as a multiracial queer person in recovery himself, Brad is passionate about creating culturally responsive and affirming resources for the LGBTQ+ community focused on mental health, substance use, wellness, and belonging. Brad, thanks for being with us. We appreciate it. We also have Betsy Kraft. Betsy is a peer navigator with the Office of the Municipal, that is a difficult word, Municipal Public Defender with the City of Denver. Betsy enjoys leveraging her lived experience with houselessness, the criminal justice system, mental health, as well as substance misuse to develop meaningful partnerships with trauma-informed community providers to support the peers that she works with. Betsy 100% believes in the peer support approach and working alongside peers as they build hope and resilience in their lives. Betsy, we're so thankful you're with us. We also have Chrissy Evans. Chrissy is a peer specialist with integrated insight therapy in Delta, Colorado. She has previously worked in juvenile facilities in her home state of Pennsylvania and with the Young Offender Program in the Women's Prison in Lusk, Wyoming. She currently works in the flagship Impact Program and has created and runs a program to help people obtain their high school equivalency. We appreciate you being with us, Chrissy. Thank you. And last but certainly not least, we have Lindsay Saunders Velez. Lindsay is a former foster child and youth from the Division of Youth Services. She is now the founder and the senior executive director of the Colorado Justice Advocacy Network, which is an organization that aims to provide equal access to justice for individuals who are justice involved, safeguard the rights and liberties of such individuals, and as well as resolve the matters in a timely and efficient manner. Lindsay also serves as a commissioner of the Colorado Jail Standards Commission. Thank you so much for being with us, Lindsay. We appreciate it. And with that, we welcome our wonderful group of panelists. We're going to jump right into it with a few questions. I would like to ask these questions in the order that I introduced you, just to keep it kind of organized since we're all virtually still. So at this time, we will begin with Katira. Katira, I wanted to ask, first of all, and the rest of the panel can be thinking about this, what is the definition when it comes to culturally competent care? What exactly does that mean? And when we're talking about it, what should someone seeking competent care really be looking for?
So, as you mentioned, I'm a refugee here, and I started my work in advocacy in 2019 with Spring Institute to increase access to quality early childhood education for dual language learners. And 10 months ago, I gave birth to my baby boy. And during my first visit, I noticed lack of the cultural and linguistic responsiveness of the care. So culturally competent care is one that acknowledges the importance of culture, incorporates the assessment of cross-cultural relation, recognizes the potential impact of cultural differences. And I have my baby boy with me, sorry for that. Expands cultural knowledge and adapts services to meet culturally unique and linguistic needs. Cultural competency offers a pathway and a framework to reach the goal of better health for all. Culturally and linguistically appropriate services responds to each person's individual preferences and needs. They also help improve outcome and decrease disparities. And good interaction between patient and provider. That's what I notice a lot. And that happens because of the lack of linguistic and cultural competent care. So also, in order to treat a patient or say someone in need of help for the care and support, there's a need for the communication. And if you can speak and understand the language of that person, how that communicate will be beneficial and more effective. And this is what I noticed during my first visit. That was actually a visit with my provider for my first pregnancy visit. And I was offered a paper that had a list of questions. And those were all just in English and Spanish. And I speak during Pashto and say, okay, so it is really not responsive to my need. I understand English, but what about my other people that doesn't speak these two languages? So I can share more when you have more questions, but these are the experiences that I faced difficult to really have access to these care. And I heard a lot of stories and experiences in the community that I am connected with.
Well, thank you for sharing, Katera, and we're definitely going to have more questions for you. So we look forward to hearing what more you have to say. This is one thing that I find so fascinating about this conversation is we have so many people with diverse backgrounds that when I ask this question, we're not going to answer exactly the same in any way. And Brad, I want to get to you next on that exact same question for you. What is culturally competent care? And what should someone, I know you specifically work with the LGBTQ plus community, so somebody within that community be looking for?
Yeah, it's a great question, Jordan. I think that, a more layman's definition of what culturally relevant or culturally responsive or culturally affirming care could be is, can I show up as a patient and be my true, authentic self, bring all of me to that encounter and know that the person sitting across from me, whether it's in person or virtual or whatever format, is going to be able to receive me and provide care based off of who I bring into that space, with no judgment, with curiosity, and with kindness and affirmation, and hopefully as little bias as possible. We all have biases. That's part of the world that we live in. But as behavioral health providers and professionals, it's exceedingly important that where we enter into a relationship with someone, and that's what behavioral health care is, that we are seeing that whole person. And a lot of times that means not making assumptions. So for someone in the LGBTQ plus community, that could look like 1,000 different things. And not all of that's just like what happens in the therapy room. So if I'm looking for an inclusive practice, I might ask, do the intake forms allow for myriad gender identities? Am I allowed to be myself in this space? Are there gender neutral restrooms? Can I use these facilities in a way that is resonant with how I'm showing up and what my identities are? And do the staff there, the individual person that I'm talking to, but also the environment that I'm receiving care in, does that feel like a place that is comfortable and kind to me? Do the staff that are there, do they look like me? Do they maybe share some of my identities? Do they engage in ongoing training and DEI efforts to make sure that the language and the language and the information that they have today is not the language and information of 5 to 10 years ago. And specifically for the LGBTQ plus community, that language and the way that people identify is constantly changing and constantly shifting, which is a great and beautiful thing. And it requires ongoing education and engagement and connection to that community. And so I really think that that's one of the things that we try to tell some of the folks that come to us for help. And like, these are some of the questions that you can ask, and hopefully what some of the providers in our space are really starting to pay attention to.
And Betsy, same question to you, because you also work with different populations there. You specifically work with people experiencing homelessness, people who've experienced the criminal justice system, people that this strongly applies to as well. From that perspective, how would you define culturally competent care? And for anybody that is within these realms, what should they be looking for?
Yeah, thank you, Jordan. Thank you for the question. And I, kind of like what Katira and Brad both spoke to, I think it's really, when I think of culturally competent care, it's really, centering the person who's sitting across from me and ensuring that I'm able to, provide access to services to best meet their needs for who they are as a person. And like Brad said, so that they're able to bring their whole authentic self and, not feeling like stigmatized or feeling, like they're not seen or heard. I work with a lot of people who, like you said, are experiencing houselessness. I work with people involved in the criminal justice system, in the jails, and in the community. I work with a lot of people who use drugs. I myself am someone who is in recovery, and I work as a peer navigator. And so what that means is I, connect people to resources, longer term behavioral health resources. So I work with the public defender's office, the municipal public defender's office, and we have a client support team, and we're a cross functional team. And so the client support team we're made up of people with lived experience, people, with like social work, educational background, as well as, our attorneys. And so we're a really diverse team, which allows us to, really provide, I think, effective problem solving and really person-centered care, so that we, because we work with all different people from all different backgrounds. And, it's our goal to really ensure that the people that we work with feel seen and heard, and that they are hopefully in a better position, that we can connect them to resources, and they're in a better position, hopefully, after a meeting with us, and, with peer support. It's really, using, I like to use a harm reduction lived experience lens, which means, like I myself have been to jail. And so I, when meeting people in the jail, I think that helps a lot to be able to just level the power dynamic, which is really important, I think, for people to be seen and heard, or to feel seen and heard. And you know, I just know, like, for myself, just in these situations, you know, that really helps. And so I think really just centering the people that we work with and like identifying what their individual needs are, and you know, really meeting people where they're at.
Absolutely. And Betsy, and to Brad and Katira, and as we get ready to hear from Chrissy and Lindsay too, thank you guys so much for being just so vulnerable in this. We know you're not just speaking from your professional experience, but from your personal lived experiences as well. And the courage that it takes. I hope everybody that is tuning in recognizes that. And we just appreciate the sincerity. With that, I want to ask that same question now to Chrissy. Whenever it comes to culturally competent care, within the groups that you work with, what does that mean?
So I work with a few different groups, but mostly with a lot of people in the criminal justice system or experiencing homelessness, very similar to Betsy. I have personal lived experience. I did some time in county jails in Colorado, and I also did some time in county jails in Wyoming, and I ended up going to prison there. I got my peer specialist certificate, and now I work for Integrated Insight. And one thing that I noticed in all of the jails that I was in was people with behavioral or mental health problems were really getting almost no treatment, you know, like some meds at night, but like I was living with these women for 8 months while they were hearing voices and, you know, not even capable of going through their everyday life. And that was like so sad to me to watch them sit there for so long. You know, some of these women on like very small bonds, right? Because they don't have family who support them, or, you know, they've driven everybody off in their life. And so while they were waiting to go to trial, they were just sitting in this jail, you know, not really getting the help they needed. And then when I got out, I met the man that I work for now, and he was opening a program up called the Impact Program, which I work with now. So when someone's found mentally incapable to stand trial, instead of sitting in a county jail for 8, 10, 12 months to wait to go to court, we get them bonded to our program and bring them there, get them a therapist. Like, they have many things they have to do. They have to, you know, be on some kind of med regimen. They have to see their therapist. They get connected to a peer. They live in a house where there's constant supervision, and their life isn't just put on hold because their mental health issues keep them from understanding what's going on in court. You know, also I work at a program called Success House here, which is with women who are either involved with DHS with their children or getting out of jail in early recovery. Oftentimes what I personally face, and I've seen a lot of clients face, is when you get out of jail on probation, you're going right back to what you were doing right before you got arrested, right? And so you're going back to a home that has drugs in it, or, you know, not a great living situation, homelessness, all of these things that we've been talking about. So Integrated here started a program where they can be referred by DHS or their probation officer. We give them a place to stay for 3 months. We help them get into therapy, and it just, from my own experience, until someone looked at me as a person instead of a number and said, like, what can I do to help you get back on your feet, Chrissy? You know, that was what was missing the first few times I went through that, you know. So I'm really grateful to be able to offer that to people now.
Yeah, absolutely. I mean, thank you for sharing that, Chrissy. It sounds like at the root of all of this, it's have a basic understanding of who you're talking to, and, you know, not just kind of the help that you think they need, but ask them what kind of help they also believe they need. Lindsay, I'm curious for you as well. You know, we mentioned to the group that's joining us today that you are a former foster child and youth from the Division of Youth Services. You also have personal lived experiences and professional experiences to add to this. For you, again, what does that culturally competent care look like?
So I was like, I spent my whole entire youth, I was either in a foster home or in DYC. So when I was in a foster home or in DYC, all the decisions were made for me. I was always on some type of medication. All the decisions were made for me. And I was acting out. So competently care starts with, for me, is with the client. You have to have the client in the room. If you're always making the decision for the client, that is not the client's treatment plan. That is your plan. If you do not have the client in the room, the client is not going to engage in that plan because they're not making the plan for them. They're not saying, hey, this is what I need to get better. Because you have to sit down and say, hey, what do you need? That's where it all starts. It's like, hey, what do you need? When you say, hey, what do you need? And they're like, hey, this is what I need, this, I need that, I need this. Then you sit down like, my program offers this, this, and this. Or my program does not offer this, but I do know a program that offers that. But if you're not asking what does the client need, you're never going to get anywhere. If you're always making the plan for the client, you're never going to get anywhere for the client. You're just making selfish decisions for yourself to get money for your program, and you're not actually helping the client. You're only making money for yourself. And that's just how it was for me. So that's just advocacy that I do for clients that come through my doors, is just like, hey, have you ever asked a client like, hey, this is, because a lot of clients that come through our doors is like a lot of assaultive clients, like they assault staff all the time. And then it's just like, have you ever asked a client what do they need? And they're like, well, no, because they're always assaulting staff. You're like, well, hey, let's just go ask them what they need. And they're like, I just want someone to listen to me. That's just the basic. They're just like, listen to me. And then staff are like, okay, what do you need? They're like, I need time out of this cell. I'm tired of being locked up 23 hours a day. And you're like, but you assault people. But I've been locked up 23 hours since I've been here. So the only time I get out is like if I refuse to come out, or if I assault someone, because if I assault someone, you have to move me to a different area. So the longer I assault someone, the longer I have some type of human connection with someone.
And ultimately, yeah. And ultimately they seem like they're stuck in that cycle until they get what they need, which you can only figure out by asking them that very question.
Yeah.
Well, Lindsay, I want to kick it back to you with this follow-up question. And as you were talking, I saw everybody's heads nodding along, seeming to agree pretty much with every single thing you were saying. This is the part where I wish I could see everybody else who is tuned in this too, because I bet you a lot of people were nodding along. You're saying that that person needs to be in the room in order to give them the quality of care that they actually need. Is that happening right now, or what's occurring now that's resulting in, poor care for your community?
So like when I get invited to like staffings, I refuse to participate in staffings if like the kid or even the adult is not in the staffing from the time the staffing starts to the end of the staffing, because I refuse to talk behind the client's back. It's not fair. It's not right, because this is about the client. It's just not right. I don't see, there's nothing ethical about it. Because there's nothing that we should be talking about the client behind their back. There's nothing that we should not be saying. If we should not be saying something about the client to them behind their back, then we should not be saying it at all. We need to be upfront about to the client at all points and times, to them at all times. So we need to bring them in the staffing so that they know what they need to be doing. So like say DCPs, like I invited to DCPs where where they make decisions about should a kid be committed to the Division of Youth Corrections. And sometimes they don't get brought in until the end of it, where they are told like, oh, they're getting sent to the Division of Youth Corrections. I don't like how they're brought in at the end of it. And then at the end of it, they're asked, what do you need? I don't like how they're brought in at the end of it because the decision's already made for them. Because it's BS, like you're now asking them, what do you need? That's not client-centered. We already made the decision, what do you need? So we already made the decision what you need. Or MDT. So to answer your question, we don't already do that. There are certain facilities like Montview Youth Services Center, Platte Valley Youth Services Center. They already have those approaches where they, the youth is already in the meetings from the start of the meeting to the end of the meeting. Where they're involved in their treatment, where they are like, what do you need? And if they can't get them what they need, then they look at, maybe this is not the right facility for you. And they look at other facilities for them. Or if they don't have that service, what about DBT? What about EMDR? They look at, if we don't have services, what about adding services or bringing services into the facility? But as a systems, as of like mental health systems, are we doing that as a whole? No, we're not doing that as a whole. We have a lot of work to do to make sure that we are culturally doing that for everyone. We're not doing that as a whole. Would I say if I put myself in there right now, and I wouldn't feel comfortable putting myself like, oh, if I had like a mental health crisis and I was right there, would I feel safe? I wouldn't feel safe myself. Somebody would be making all the decisions for me.
Brad, I want to get to you next. The same thing, you were nodding along right there, that the person needs to be involved in the decision-making process. Do you see this happening within the LGBTQ plus community? And if not, or what else is kind of hindering people being able to access this culturally competent care?
Yeah, well, so I did want to say that everything that Lindsay was saying really resonated with me, and the point that I'm going to sort of come at is it's sort of a different not being in the room, and that is for so many LGBTQ plus people, they just never make it to the room, period. And there are a lot of different reasons for that. There's still like so much stigma and financial barriers in regards to just getting in a room with someone. And of course, I'm talking with folks that are sort of like outside the criminal legal system. There are plenty of LGBT plus people that are in the criminal legal system that are experiencing exactly the same things that that Lindsay and Chrissy and Betsy were speaking of. But for those that are not involved in that system, we're having a really, really hard time getting folks connected to anyone, period. We have a pretty significant workforce shortage in behavioral health across the state. And in particular, for the communities that have the greatest needs for behavioral health, there are far, far fewer providers that either share their identities or that are trained in providing culturally relevant care. And people don't know where to go. So if I just take a quick rewind. So right now, as of January 1st, the ACLU has been tracking 385 anti-LGBTQ plus bills currently in the US. It's awful. It's everything from banning gender affirming care, don't say gay bills, attacks on gender neutral bathrooms, drag performances, trans rights in athletics. And LGBTQ plus people in general, but it's specifically youth, transgender and gender diverse individuals and people of color, they are already facing the most barriers of care in terms of finding someone who can see them as they are and who has an understanding of where they're coming from and what their challenges are and how to engage with them in such a way that allows them to be seen and show up as their authentic selves. And everything that's happening in the world right now, politically and legislatively, is making it even harder for folks to say, one, that people see me and that I'm worthy of deserving care. And also figuring out how to navigate our pretty challenging and pretty obtuse behavioral healthcare system to find like, who is a good match for me? Because everyone needs a therapist or a provider that, you know, that matches them in some way. It's a relationship. And I think for the LGBT plus community, there are just very, very few people that fit that criteria. And they don't all have to identify as LGBTQ plus, although that is definitely a benefit. I think it's a benefit for anyone who's in part of an oppressed community to have someone in the room that matches their experience. But that training doesn't exist, or isn't. It's not transparent who has had training to be able for someone to make a decision about like what is safe, what is comfortable, where is a place where I'm not going to be re-traumatized or harmed or misgendered or dead named. And if our behavioral health care system is one that does at least as much or maybe even more harm than it does good, it's not a system that folks are going to want to reintroduce themselves to once they have an experience that dehumanizes them. And so I think we've just got a lot of work to do in terms of making sure that when folks enter a space, when they actually get to a room, that they've got someone who's got their back. But we're even having trouble just getting folks into a room, period.
Brad, you mentioned, the workforce shortage and the lack of resources or the lack of connectivity to resources. I'm also wondering, even if you had those resources and you were able to put, people with the professionals that can actually help them and that do understand them, can you talk about, maybe a lack of trust that people might have based off of persecution they may have faced in their lives from a young age? It's not like they walk into a room, even if they have the resource, and they just start, spilling everything out. It's that trust has to be earned. And for people of marginalized communities in general, that's not very easy a lot of times.
No, you're right. And, I think that one of the things that could potentially help in that circumstance is trying to reduce the stigma of mental health challenges overall, where communities are seeking their information from. And so there's a lot of distrust in the behavioral health community, or with behavioral health among many communities, because there has been a lot of trauma. There's been a lot of dehumanization that has occurred, and much of that is not necessarily intentional, but when folks are interacting with systems that are not built for them, that is what's going to happen. And so, some of the things that we've been really trying to think about is who do folks trust, and trying to work within those systems to break down that stigma a bit. And maybe who people trust are the folks that they go to church with. Maybe people who trust are the folks at their community center or involved in an extracurricular activity. There is a barrier for going into a professionalized setting and sitting down and really making yourself vulnerable, not having a relationship with the person that is alongside of you. And so I think there are a lot of really interesting organizations that are doing some great things, including ours, to really try to break down that stigma by meeting communities and individuals where they are, because we're not going to fix our behavioral healthcare system tomorrow. And so what does it mean to sort of like bridge that gap? And I think it's really all about family, community, and personal connections that people already have.
And Betsy, that trauma and those barriers that Brad was just talking about, that's not isolated to the LGBTQ plus community. You were nodding along as he was talking as well. I'm curious, where you see those barriers, what you see that's occurring right now that's leading to poor care for your community.
Yeah, thank you, Jordan. And that is such an important question. I, work with a lot of people, like I said, in the jails and in the communities, and across a lot of different intersectionalities. And I think one thing that like a lot of people don't talk about is like health disparities amongst, people who use drugs, and the treatment modality, for a long time was just abstinence based. And as a person who's lived that and has been to treatment 9 different times, all the way from, a medical or social detox, all the way to a 30-day, to a 2-year therapeutic community behavioral modification programs. I can honestly say that a lot of the programs cause harm to people. Especially, a lot of the programs that, may be mandated by the criminal justice system. And it's, I have a stat here, 21.2 million people age 12 plus needed substance use treatment in 2018, but only 3.7 million received it. And I think, it just, we now have, we have different levels of treatment, but there's not a lot of options for people who are on Medicaid. And like these lists are so long, and that's why it's really frustrating. A lot of the bills that are coming across, like I'm very harm reduction focused, because that's what saved my life. It was somebody, it was the having access to syringe access programs, while being unhoused, while being an IV drug user, while, living on the streets. Those were the places that allowed me in. Those are the places that, accepted me how I was. And I think, like, if it wasn't for those programs, like, I wouldn't be alive today. And I think we need a lot of different tools in our tool belt, and to sorry. That's why I'm, it's good that now we have like medication assisted treatment. However, access to medication assisted treatment isn't where it needs to be. Like the fentanyl accountability bill in 2022 mandated that we have medication assisted treatment across all jails in Colorado by July of 2023. And we're not quite there yet, but I work with a lot of clients in the jail, and a lot of people get missed. A lot of people who need medication assisted treatment do not get it in the jail. And we know what happens, right, when people get out. And I can speak to that. I've overdosed every single time I've been released from Denver County Jail, many times. And so it's frustrating. It's really frustrating. Here we are in 2023, and I know we're working to improve this, and I know, but I think we need to have more people with lived experience at the table. We need to have more peer-led review boards with all this opioid abatement money coming down the pipe. We need, people who have been through these programs, who can speak to which programs work and which ones don't, so that we're funding the ones that are doing a good job and the ones that aren't actively causing harm. I think everybody, wants to get in on the medication assisted treatment, but we don't necessarily have trauma informed doctors that, should be prescribing medication assisted treatment. I love Colorado Coalition for the Homeless, because they do walk-in hours, 1 to 4, and they really meet people where they at. They have a street outreach team that goes out, every Friday and does medication assisted treatment. I know the aid center that just recently opened at 14th and Elati, they're working with the Denver Detention Center to have MAT providers at the aid center, so that when people are released from jail, if they didn't get inducted on MAT, they can go across the street, you know, and get that service, which is so important because the increase or the likelihood of a person overdosing is up to 129 times greater for the first 2 weeks when they're released from jail. And so we, you know, we need to be meeting them where they're at in the jail, or making sure when they get out that they have a great reentry plan, overdose prevention, you know, plan. And that's a lot of what myself, you know, I do, as well as the people on my team, the amazing individuals I work with, is creating reentry plans for people so that they don't get released to the streets, because I know what that's like. I know what it's like to be in treatment or to be in jail and to not have anywhere to go, and to be really scared that I'm just going to go back to where I came from. And we need to be doing a better job. Like, why are we incarcerating people and mandating MAT if we're not going to be, you know, giving it to them the way that the medication was designed, which is when they're in active withdrawal? You know, we have a lot less diversion going on when we give people the medication when they need it, as opposed to when, you know, as opposed to anything else, right? It just needs to be when they need it. So I know that was a lot, but I think you know, there's a lot of work to be done, but I think, you know, there's a lot of successes as well. So thank you.
And Betsy, I hope you recognize that what you're doing and your work and your testimony from your heart, you're helping more people than you know. And I don't know if you had time to see any of the comments scrolling on the section, but a lot of people are just so thankful for your vulnerability. So we appreciate that. We've been talking about this proverbial room, right? And oftentimes physical room that we all need to be involved in, that you need people with personal experience in that room to help make these decisions. Christy, I want to get to you next because I've been watching you nod along with every single person who has been talking, and I know you have something to add here.
I think that everybody really hit the nail on the head. I think that the peer specialist movement has really helped us to get more involved in our clients' lives, where a therapist is not as accessible as we are, right? And so when they're experiencing suicidal ideations or a mental health crisis, whereas they may be able to call the office, right, and see their therapist the next day or the day after, they can text my phone and I can go over and see them, you know. My young clients that are calling the crisis line saying they're suicidal and telling me that they don't have any friends and they're being bullied, like, you can work on someone's mental health and how they think about things so much, right? But if you don't change what's going on in their life, then the same issues are there and the same things are going to keep resurfacing. So I think that, like, having a more hands-on approach is really helpful to be able to help some people get out of that endless cycle of the same, just going back to all of the same problems, the same things that are like triggering these mental health issues.
And Katira, I want to get back over to you too, because you raised a lot of good points at the beginning of this discussion. You know, you talked about language barrier being a really big factor here as well. I'm curious, I want to kind of move into the solutions portion of this conversation. We've addressed a lot of holes that, you know, need to be fixed. As you're listening to this conversation and you know, with the points that you've already made, what do you see that can be done better, that can be done right now? Because as we heard Brad say, this change may not be made overnight or, you know, in the near future, but what can be done now to start setting us on the right course for this?
So providing interpretation and translation, I can share one experience from my friend. So she shared with me that my friend's friend, so I was looking for more stories and more experiences in the community. And so that person shared that she was feeling anxiety and she was depressed. And then she had an appointment with the provider. And during the conversation, there was some misinterpretation of what she shared. Since English was not her first language, she kind of saying that she had an argument. She said she had a fight and that put her in trouble. and increase more barriers and challenges for her. So that was a big like flagging point to me, like, yes, here is the problem. So this is really important, that there is communication between the provider and the patient in a way that is understandable to both sides, so that the right and correct information are captured. So in my opinion, or I can say my recommendation is to provide more interpretation in translation. As Brad mentioned, stigma is a huge barrier. A lot of people, they will never share like about their what they are suffering through and about their experiences. A lot of people are hiding, and it gets, you know, more and more severe to them. So it's really important that we increase awareness, education, provide more languages, culturally increase the cultural competency of our providers, and create pathways for those that have foreign degrees and that have at some level experience working in back in their home country. I'm talking more about refugee immigrants, so that they can join the workforce and can better serve, you know, the population that at some level they share the culture. When I had that first experience, I know I'm an advocate, I'm looking for opportunity. And then I start talking in my circle with other women. Do you know, here is this support exists for pregnant women if you are, feeling any mood swings or anything during the pregnancy? Do you know there's the support? And they didn't know about it. And in addition to that, and you are hearing my baby smile talking too. He's supporting me too. So that was a big flagging point to me as well. Like, okay, there's lack of education. People don't know what they are feeling and how they are going through this difficult process, you know. That was really really, I would say it really made me sad, like how these women are going through this difficult times. And another woman shared with me that how those pregnancy mood swings really impacted their personal relationship, because both partners that didn't know about these changes that may happen to pregnant women during pregnancy. And it really like impacted their relationship, and finally they were able to divorce, like they divorced. And this is again lack of information and awareness, you know. It's really important. And when that first visits that happens during the person's pregnancy with the provider or doctor, at the time when I was with the doctor, I told him like, okay, this paper is great, it's good, it's okay, it at least serves English speaking and Spanish speaking population, but I'm requesting, if there is, you know, there are regular visits with the doctor during pregnancy, there should be regular visits related to your behavioral health, you know, as well. Not giving that paper in your hand, whether if you indicate or answer those questions and based on that first screen, you are given that appointment. No, there should be, like, as all regular visits, there should be regular visits for behavioral health as well. So we ensure, you know, these moms are doing great, since that impact, you know, both the mental health and the physical health of a mom impacts the baby health. So we ensure that babies are thriving, they are not facing any developmental delay in the future. Thank you.
Katira, that was, you gave us a really good platform there as far as solutions to jump off of here. I know that we have a lot more people that want to ask a few questions, and we're going to get to more of the questions a little bit later in the program. Those are going to be the audience questions, because I want them to be able to have a chance. I just want to finish with this last question, and we just have a few minutes because our keynote speaker is great, and I want to make sure or that they have plenty of time. Excuse me. What can your advocacy partners do to make those changes within our system. And honestly, free for all, for anybody who would like to just jump in.
I'll say one thing is, you know, this is a long-term game, but what does it really mean, like, to build up our workforce? You know, our education system, like all of our other systems, are not inherently built to include everyone, which means that the concerns that we have about having providers and peer support folks with identities that match and that resonate with folks that are actually in need of care. How are we making sure that we're creating opportunities for folks to get the training and education that they need when that's not the profile of a typical school that is churning out behavioral health providers? Who the profile of those graduating classes does not match the profile of the folks who are most in need of services. And I think we really need to think about how to turn that around. And some of that is access, some of that is, you know, like financial barriers. And so, like, what could it mean to have paid internships and apprenticeships that allow folks to allow at least some folks to go to school and be able to survive with the experience that they're getting, that are going to help pull them into their field? What does it mean to think about the behavioral health field in some of the same ways that we think about the clinical health field? And is there loan forgiveness possible for people that are doing work within their own communities? Addressing rising tuition costs, and like, what does it mean for opportunities for non-traditional students? Like, to have a sort of like hyper educated and very specific track for folks to go down to be able to provide the kinds of care that people really need, it's just going to continue to perpetuate the challenge that we have of a mismatch between the folks who need care and the folks that are providing it. And we will all be better off, I think, if we sort of try to close those gaps a little bit and provide more opportunities for folks to be able to treat folks, build relationships and connection with folks, and bring more of their perspective to the system, so that the system eventually ends up looking more like the profile of the communities that we're trying to support.
Awesome, Brad. Thank you. Again, we're going to get to hear from our panelists again coming up in just a bit with all of the audience's questions. But right now, I'm so excited about this next portion. It is my great pleasure to introduce our keynote speaker, LJ Jensen. A little background about LJ before we hear from them. LJ Jensen, LMSW, is a queer trans psychotherapist at the Gender and Sexuality Therapy Center in New York City. They are a graduate of the NYU Silver School of Social Work. They have advanced training in harm reduction, liberation-oriented practice, and trauma-centered care. They specialize in issues with LGBTQ+ communities, with particular focus on the intersection of queer trans experiences and embodiment. LJ, thank you so much for being with us.
Thank you. It's such a joy to be here. I'm going to go ahead and share my screen. All right. So, hi, everyone. Before I get started, let me make sure everything's here. All right. Before I get started, I just want to say how thrilled I am to be speaking at this event. I want to thank everyone at Mental Health Colorado for their work in putting this together and inviting me to give this talk. Special shout out to M. Trotton for their unparalleled passion for this topic and bringing so many of these issues to light. My name is LJ Jensen. I am a psychotherapist at the Gender and Sexuality Therapy Center in New York. I'll be talking today about equitable access to eating disorder treatment, the urgent need for liberation-based, culturally competent approaches to care, including harm reduction. And I'll be finishing off with some action items, as well as some gentle, loving reminders for people with eating disorders and the people who love them. as I start, since I'll be talking about my lived experience, I want to name a few of my identities and my privileges, because eating disorders, including diagnosis, treatment, recovery, and advocacy, are all so deeply political. So my lived experience with an eating disorder is informed by the identities and especially the privileges that I hold. I am a white, queer, trans, neurodivergent, and currently able-bodied therapist with lived experience with an eating disorder. I live on Lenape land, colonially known as New York. Some additional privileges that I hold are that I have an advanced degree in my field, which allowed me to advocate for my needs in treatment settings in ways that were heard and taken seriously. I had financial, housing, and food stability throughout my course of treatment. And lastly, and probably most importantly to eating disorder treatment, I have not faced size-based discrimination and oppression, which means that when I needed care, my eating disorder was generally taken seriously and insurance companies were willing to cover the cost. Again, it's so crucial in this work that those of us with these privileges name them very openly and clearly, because otherwise we risk perpetuating this very flat, very singular, very privileged narrative that anyone can recover. And I want to be very clear here that I do believe fundamentally that everyone should be able to recover. And I also know many people who have recovered despite complicated, oppressive, and challenging circumstances, and who were able to find sources of resilience despite everything they're facing. It is possible, and I hold hope that we can live in a world in which anyone can recover. But the reality is that not everyone, and in fact, most people, don't have the resources that are often crucial to the recovery process. So all of which is to say, while I'm recovered and I will be speaking to my lived experience, I really refuse to place myself in a position of being a success story for a system that just fundamentally doesn't work and excludes most people who suffer. Super quickly, I want to name some of my theoretical grounding and lineage in this work. I just would not be the therapist, advocate, social worker that I am without any of the people listed here, who I just want to specifically name so that we can honor their work, which frankly often goes unpaid and unacknowledged. I highly encourage you to screenshot this slide. If you don't know any of these names, write them down, seek out their work if you can. They include Gloria Lucas, Shira Hassan, Miriam Kaba, Eli Clare, Aubrey Gordon, Sonia Renee Taylor, Dr. Jenny Wang Hall, and Rebecca Lester. And similarly, everything I'm talking about today is rooted in the legacy of harm reduction, carceral abolition, trauma-centered, liberation-oriented, and relational frameworks of care. I think that no matter your lived experience, your job title, or your involvement in this work, these theoretical groundings can help so deeply with informing how we as people show up for one another and can make this world more equitable, especially when it comes to providing culturally competent care. So let's get into it. Why am I talking to you today? So to give you the shortest version possible of my story, I survived an eating disorder on and off since I was a child. I didn't know or have any awareness that these thoughts and behaviors around food were an eating disorder until I was in college. And by that point, I didn't really have access to quality therapy. And when I tried accessing therapy, I was minimized, dismissed, and just told it wasn't that big of a deal. I did everything I could at that time to recover on my own with marginal success. I like to joke that I tried to read my way out of an eating disorder. I got really passionate about issues like access to mental health care, systems of oppression, weight-based discrimination. And that really pushed me to examine my own relationships with my body and with food in ways I never had before. But without any other care, that frankly only scratched the surface. And within just a couple of years, my eating disorder came back with a vengeance. So as so many of these stories go, what started as little slips here and lapses there ended up completely spiraling over the span of a few years, and I got extremely sick. I couldn't really figure out why I was suddenly so attached to my eating disorder. I knew I didn't want to be doing what I was doing, but I couldn't find a way out. And eventually I hit my breaking point, and it was clear that I couldn't keep living this way. And if I didn't get care, I was probably going to die. I went to residential treatment in Denver, which is why Colorado as a state holds such an important place in my heart. And as much as that experience, and especially my treatment team and the other patients I met there saved my life, I also started to become acquainted with the ways that eating disorder treatment and standards of care fail so many people. And personally, while I was stable in my behaviors, by the time I left, I didn't really heal or recover, even though on paper it seemed like I did. I learned how to perform recovery, mostly out of fear of not receiving care, but I wasn't provided space to have a sense of self-determination to decide what I wanted my own recovery to look like. So I relapsed within minutes of leaving treatment, and that started a journey of rotating in and out of higher levels of care. Throughout that time, I started coming out as trans, first to myself and later to my loved ones, which helped me really understand that a primary function of my eating disorder was to change my body to feel gender affirmed in the absence of gender affirming healthcare and to feel in control while facing both internalized and systemic transphobia. Over time, I grew increasingly wary of the failures of eating disorder treatment. And I genuinely believe that what helped me the most was learning tools to advocate for myself and escape the performative and punitive requirements that treatment taught me were essential to recovery. I learned that I could only really recover when I stopped trying to be the good patient, which again is a huge privilege to resist that paradigm, because recovering in a very particular way is often essential to getting insurance companies to cover treatment and in getting treatment programs to keep you in their program. So I was able to start recovering when I was given the opportunity to define my own recovery. And as I give this talk, I am fully recovered. That word recovered is complex, but I use it intentionally because I got to define what recovered means for myself, which for me is living a life in which my eating disorder is not at the center, living closer to my values, and accepting that hard days, slips, lapses are part of recovery and not oppositional to recovery. It means embracing my queerness and transness and healing and caring for my trans body every chance I get. I am now a full-time practicing therapist working with primarily queer and trans folks, both adults and young people, and I work with many people with all sorts of eating disorders, supporting them in defining their own recoveries and their own paths. So given all of that, I just want to share what I've learned, both through my lived experience and through my work as a therapist. So first, eating disorders are fundamentally impacted and perpetuated by systemic oppressions, including anti-fatness, white supremacy, patriarchy, homophobia, transphobia, ableism, colonialism, and capitalism. Simply, we live in a profoundly disordered world in which we are given clear messages about whose bodies matter and how to live in our bodies, who should be allowed to exist exactly as we are. With that in mind, BIPOC, LGBTQ+, fat, disabled, indigenous, low-income, neurodivergent populations in particular are flooded with both historical and present-day traumas from the world we live in, telling people that their lives and bodies are unworthy of basic needs being met, including the needs for safety, love, care, resources, and community. Eating disorders and the barriers people face in finding comprehensive care are a reflection of our disordered world. And all of the systems of oppression that I named, and especially their intersections, make eating disorders a form of survival. So if we as care providers are missing this, we simply are not providing culturally competent care, and we're missing the big picture. Which leads me to point 2. Eating disorders are an externalization of our innate wisdom to survive the otherwise unsurvivable. Eating disorders do not come out of nowhere. They're not a choice. If you're not familiar with the language of harm reduction, what I'm about to say might sound uncomfortable, but stick with me. Eating disorders are coping skills. They are morally neutral, just like taking deep breaths or journaling your feelings or talking to a friend or turning to substances. They are risky and they are at times deadly, but they are not a personal moral failure, nor are they a choice. To quote Rebecca Lester in her wonderful book, Famished, which I highly recommend, eating disorders are themselves survival strategies. This may seem counterintuitive given that they can and frequently do kill people. What I mean is that they are strategies for existential survival that include but extend far beyond the physical body. They are about wanting one's voice to be heard as a vital contribution, dismissed as a cry for attention. They are about wanting a response, not an answer. All too often, eating disorders become occasions for the opposite, for silencing and misrecognition, for erasure and denial. The eating disorder helps to make sense of life conditions that otherwise would be irreconcilable. So while eating disorders on their surface might seem to make little logical sense as survival tactics, no one would turn to an eating disorder if other mechanisms of care, support, and survival were available to them. It's not your fault for having an eating disorder. And as long as the world we live in systemically makes people feel like their lives don't matter, eating disorders will persist. They're full of wisdom, and the eating disorder part of a person is often the part that needs the most attention, agency, and trust. 3, systemic barriers to treatment make recovery inaccessible and often undesirable for the majority of sufferers. So according to some studies, somewhere between 80 and 90% of people with eating disorders will never access treatment. And of the people who do, typically only about 1/3 to go on to live a life without their eating disorder. That number is hauntingly low. I'm going to name some of the systemic barriers to care. Please know that there are so many more. This is just, again, scratching the surface. So we'll start with the fact that eating disorder diagnosis is based on BMI, which we know very well at this point is an arbitrary, racist, and inaccurate tool for diagnosis of any medical condition. People with eating disorders often face weight discrimination for admission to care, as well as throughout treatment programs. Eating disorder treatment can be alarmingly fat phobic, and this includes treatment programs that claim to practice from an all foods fit or a health at every size model. It's really not uncommon for treatment centers to encourage higher weight or fat clients to lose weight or treat them significantly more poorly than their thin counterparts. It's not uncommon for treatment centers and providers to tell patients things like, "We won't let you get fat." The fat phobia within treatment programs themselves make them unsafe for the majority of people who suffer and can in fact perpetuate the disorders that they are purporting to treat. There's the high cost. Treatment centers often cost around $2,000 a day for residential care without insurance. So if someone is going into treatment, unless they have access to extraordinary amounts of wealth, they need insurance to be on board. This is a huge problem as managed care systems prioritize profit over people. So plain and simple, these systems give up on people whose lives they determine are not worthy enough for treatment or whose bodies and experiences don't fit an extremely narrow understanding of eating disorders. We face a crisis due to the lack of competent, diverse, and affirming treatment providers. Eating disorder treatment, typically speaking, is built around and for a very specific and very narrow set of identities. It's full of assumptions around what kind of treatment should work, which leaves most people behind or even further isolated in their attempts to heal. The vast majority of treatment providers hold oppressive or majority identities and then reinforce implicit and explicit bias while treating clients. This field is overwhelmingly full of white, thin, straight, cisgender women. And while identity, of course, isn't the only way to create that strong alliance, when providers don't reflect and at worst minimize your experiences, treatment's not going to work. I personally was lucky to work with some providers who saw and affirmed me as a trans person, but I also worked with so many providers who questioned and doubted things like my pronouns. They doubted my frustration when getting misgendered. They questioned my need for things like gender affirming clothing and gender affirming healthcare, and even questioned when I asked for conversations around body image to be inclusive to queer and trans identities. So these experiences made me feel like I didn't belong in treatment and like my providers were treating the behaviors, but not the root cause of what was going on under the behaviors. With that in mind, for people who are able to access treatment, it's not uncommon to be traumatized while in higher levels of care. This can come from many places, but one is that it's relatively standard practice to enforce punitive measures when people don't recover quickly enough or in just the right way. I witnessed people get isolated into their rooms as a punishment for not eating. I witnessed people receive other punishments like not being allowed to go outside as a result of not completing a meal. I've seen punishments for people not being allowed to speak with their therapist due to self-injury. So all of these were punishments for people who struggled with the disorder that they were there to get help for. It's a horrific aspect of treatment that needs to change. It is so far from culturally competent or any competent care. And when people get traumatized by these systems, it's rare that they'll want to go back for more help. And frankly, who could blame them? And lastly, this field really suffers from a refusal to acknowledge harm reduction as valid and necessary. Which takes me to part 4, which is my personal favorite part. Recovery requires agency and self-determination, especially in the form of harm reduction. Treatment programs as they currently stand so often strip people of their agency. I have stories from myself and others of being in treatment programs that tell you there is only one way to recover. And if you resist that way, you will either die or you will be labeled as manipulative, difficult, untreatable, and a failure, and ultimately left alone. As a provider, I cannot think of a more effective way to reinforce someone's eating disorder than by telling them such horrible things about themselves and their recovery. In order for people to recover, they have to be met with trust over skepticism, choice over force, harm reduction over abstinence, and agency over provider expertise. People with eating disorders are the only and best experts of their experience. And when people say that a specific vision of recovery doesn't work for them, they deserve to be heard. It's not the eating disorder talking, it's their survival and their wisdom speaking out. And that's true too when people say they don't want to or aren't ready to recover at all. That wisdom deserves a chance to be seen. So when recovery is so inaccessible or traumatizing to most people, it's not an individual's fault for relying on their eating disorder when recovery systems treat them with that much disdain, mistrust, coercion, and punitive measures. Recovery requires agency in the face of these systemic oppressions and inaccessibility, and people just won't recover if they're constantly told that they're wrong or bad or manipulative or lazy for not being able to recover in these spaces. So let's get into harm reduction. Harm reduction is a valid and necessary form of treatment. It is simply not a last resort measure. It needs to be part of treatment from day one. In her book, Saving Our Own Lives, Shira Hassan writes, liberatory harm reductionists support each other and our communities without judgment, stigma, or coercion, and we do not force others to change. We envision a world without racism, capitalism, patriarchy, misogyny, ableism, transphobia, policing, surveillance, and other systems of violence. Liberatory harm reduction is true self-determination and total body autonomy. Harm reduction tells us that you are worthy of love, care, and support, no matter where you exist in your relationship to recovery. As Gloria Lucas writes, people with eating disorders deserve a bearable life and should not receive proper support only when they are in recovery. Harm reduction has allowed me to exist within my own brilliance, my own power, my own relapse, and be all of that, be completely vulnerable and completely human. In order to treat eating disorders and truly disentangle the current landscape, we have to prioritize harm reduction. Harm reduction in eating disorders includes things on the micro level, like education on how to engage more safely in disordered behaviors and refusing coercive measures like behavioral contracts, punishments, and turning people away from treatment because they struggle or are deemed untreatable. But it also exists on the macro level. Housing stability, food access, gender-affirming care, environmental justice, carceral abolition. These all impact people's feelings of safety in their bodies and lives, which when we look upstream will ultimately lead to fewer eating disorders. Harm reduction is a framework that tells us people's risky behaviors don't make them unlovable or unworthy of care, and it contextualizes our struggles in the broadest picture imaginable. It encourages us to think big, to think creatively, to imagine a better future for everybody, and provide real-life applicable skills in the absence of a more just world. Lastly, the high mortality rate of eating disorders is not only a reflection of the deadly health complications of eating disorders, it is a reflection of inadequate and inaccessible care. So something you'll probably hear people say often when we talk about the urgent need for awareness and education of eating disorders is that they are the second most deadly mental illness. Someone dies from an eating disorder every 52 minutes. That means throughout the duration of our event today, 2 people, at least, with eating disorders have lost their lives. 2 families and 2 communities will have lost someone who undoubtedly means the world to them. When we talk about this statistic, often we'll use it as evidence for the seriousness of eating disorders, the fact that they kill, the fact that they are often accompanied by other comorbidities, and it's not uncommon for them to lead people to hopelessness and suicide. But what we don't talk about often enough is the fact that this could change if we had care that actually helped people and prioritized our lives over the bottom line. Care that is rooted in community, in justice, and a fundamental belief that everyone is deserving of love regardless of their healing journey. So what do? I don't have all the answers, but I have some thoughts. Luckily, you are already doing something pretty incredible by showing up to this work and by advocating for the passage of this game-changing, life-saving bill, Senate Bill 176, saving lives through eating disorder prevention and treatment reform. You can keep advocating for principles of liberation, harm reduction, and accessible care. If you are currently surviving an eating disorder, you can give yourself so much grace for the fact that you are doing the best you can with what you have. You are surviving something horrific, not just the eating disorder, but the experiences that led up to needing an eating disorder to get by. Recovery takes a long time, and it's true when they say it's nonlinear. Your recovery gets to be placed squarely within your choice and agency. And I also want to name that if you have not been able to access a diagnosis or treatment based on any of the barriers I named and more, your eating disorder is still valid. Self-diagnosis is still valid. You are worthy of care and support, regardless of what the DSM says. Recovery is also collective. So if you are recovered, I really encourage you to examine what led you here and what you do with that privilege. I believe that my recovery means little when perpetuating systems of racism, fat phobia, and other harms. It means little when I live on stolen land. It means little when issues like our national housing crisis, police violence, climate disaster, and legislation to harm and kill trans people and children tell people that it is unsafe to live in our bodies. I refuse to sit comfortably in my recovery unless everyone gets equitable access to recovery, because our recoveries are bound up in one another, and a recognition of that collective effort is necessary for this change. If you love someone with an eating disorder, learn as much as you can and do some from reliable, liberation-oriented sources, which I'll provide in the next slide. As you learn, you will likely find yourself feeling a bit uncomfortable with some biases and assumptions you hold. So I really encourage you to non-judgmentally notice and turn towards that discomfort rather than away from it. Examine your own relationship to oppressions, body, weight discrimination. Examine how you may unintentionally perpetuate your loved one's disorder and really let yourself get uncomfortable. If you love someone with an eating disorder, I also encourage you to ask questions and focus on the feeling over the food or their body. Ask your person things like, how can I show up for you? How are you doing really? And know that you might not get a clear answer, and in fact, you probably won't. You might be told there's nothing you can do, and that's okay. Listen to their answer, turn towards their pain, even if it feels scary. Even if all you can do is show up and be a loving presence while they endure this horrible thing, your presence and safety will still mean the world. Don't rush someone into recovery nor shame them for using behaviors. Just be with them in this moment and let them know you love them no matter where they are. Finally, let's get angry. Collective rage has as much of a role in recovery as anything. As I say to my loved ones and to my clients all the time, recovery out of spite is a valid option. There is so much here worthy of our rage, grief, and disappointment. People are dying and something needs to change desperately. As Miriam Kaba writes, let this radicalize you rather than lead you to despair. I also want to extend a voice of hope within and alongside the rage. When we talk about things like harm reduction or the abolition of these massive intersecting oppressions, I think it's easy for folks to hear that as pessimism or as an assumption that recovery is wholly unattainable. And I want to be clear that I do have hope that if you are in a position to recover, you can. And for those who have found recovery to be impossible given their circumstances, there are people, including everyone here today, who are committed to changing that reality. Something I often say to my clients that I also want to extend here, where you aren't able to hold hope for yourself, I will hold it for you. I don't know exactly who is watching, who's in this room. I don't know your names, but I do genuinely mean that. This work requires hope and imagination on all of our parts, as well as an acknowledgement that when we can't feel a sense of hope for ourselves, someone else in this world is still rooting for us and rooting for our safety and care. So it's beyond time to get radicalized. It's time for us to think outside the box, to get creative. It's time for us as providers and as people with lived experience, as people who have had the privilege of recovery, people who are recovering, to just get so deeply involved with changing these broken systems. And that really starts with competent care, that starts with liberation-oriented care, and all of us joining together in this beautiful, radical room. Thank you all so much for your time. This is a list of further resources and teachings. My email is there too. Please feel free to reach out after this event, open for any questions, comments, concerns. And just thank you all so much.
No, LJ, thank you very much. We very much appreciate it. The education was incredible and such wonderful perspective, redefining recovery. I was scrambling to find my notes really quickly so I could write that down. And I know a lot of people probably were as well. So thank you very much. I'd also like to point everybody's attention to the fact that M posted in the chat for anybody who's interested in learning Mental Health Colorado's Eating Disorder Treatment Bill, SB 23-176. There is a link where if you'd like to learn more about that bill and specifically what it is trying to do, again, that is posted in the chat. LJ, we're not finished with you yet. We want you to hang around. We got the panelists back with us now. And now is for one of the most fun parts of this whole experience. This is the audience questions. This is where you have your chance to ask the panelists and LJ your questions and not hear the ones that I've already laid out in front of you. So at this time, we're going to wait for these to come in. LJ, while we wait for these questions, some people were wondering if by any chance your definition of recovery, if you'd be willing to share that in maybe a written form that people could copy and paste and hold on into their notes. That'd be wonderful. I'll just get us started with some of the questions that we've already gotten in. And I just want to treat this as an open forum. So anybody feel free to jump in. I'm curious to know, as we talk about this culturally competent care, have you ever experienced, or has your experience, impacted how you practice as a provider and the work that you do within your capacity?
I mean, absolutely. I wouldn't be doing what I do without the experiences that I've had. But also, some of the negative experiences are that I've had in mental health interactions are what push me more to do what I do. You know, I don't want anyone to have to experience that because you don't connect with one person, that there's no help for you. You know, I know that what I can offer is hope no matter what, you know, holding space, and like LJ said, like holding hope for them when they have none for themselves.
Betsy,
I want to say,
Lindsay, sorry.
oh, sorry. I think I want to say that I have had one of some of the terrible care that there were in the foster care system. So the reason why I created the network that there is because I wanted to make sure that there is not another experience that there were. Not to say that there weren't any positive experience, but there weren't many positive experiences there.
Lindsay, I want to kind of kick it back to you with a follow-up question there. You know, you said there weren't many positive experiences. What you described earlier about, you know, the world you envision as far as providing this culturally competent care, you had a lot of great ideas, and I'm wondering, you know, you didn't have the greatest experiences, but did you draw on that from all of your negative experience?
Yes. I drew on everything from all the negative experiences. So there was even like a lot of the providers that I have dealt with, there was many providers that got fired for having great ideas, and they got fired because they implemented great ideas. So yeah.
Well, we appreciate your good ideas and thank you for sharing them with us. Betsy, you have a smile on, you've been nodding along. Anything you'd like to add?
I mean, I was just blown away by LJ's presentation and just all of the intersections of like like recovery as it pertains to a person with an eating disorder, and the similarities, and like how harm reduction, a harm reduction lens can be applied to that, and how effective that is. And similarly to you know, substance use disorder. And I'm somebody with living and lived experience with both. And I just think it's, being able, like LJ was saying, like for the person to like really define that they are the expert in themselves, and that they really need to be listened to as far as like what works, and really holding space for, I really align with, I love LJ's definition of recovery, because I've been trying to find a way, to really articulate this for myself, but like it's to deny the periods of my life that maybe I wasn't on the path, or like struggling with chaotic substance misuse, or struggling with eating disorder, is like I've learned so much about myself during those times. And so to deny those parts, and to only focus on, the abstinence, or like when I was not experiencing non-chaotic drug use, or when I was, doing well with my eating disorder, like that is to deny like a whole part of me. And so I really resonated with that, because I just, a lot of people say like, oh, and I like to say first that I respect any form of recovery, and for people to be able to define that for themselves. I just know that historically, like it's been a way for people to define their recovery as like X amount of years, or this linear path, when I feel like we are denying a huge part of ourselves. I know, the times when I was really struggling taught me so much about my resilience and who I am as a person. And being able to, that's why, like, for me, I define recovery as like any positive change, because it's not just this linear path. And like, honestly, the cycles of abstinence to chaotic drug use for me was like this really violent, self-destructive cycle. And I think that like we live in a gray area, life happens in a gray area, and we just, that's why I love harm reduction so much, because it's really truly allowing the person to be the expert in themselves, and to define what works for them. And there's so much power in mutual aid and community, and like people, just being able to come together. And I'm an advocate for a lifetime. Like I don't really know much about the other times that people define their recovery as. I don't even like to use those words, because I've overdosed over 12 times in my life. And so I'm like, hey, I'm just happy to have a lifetime, and to be able to define for myself what recovery means to me. And so I just really, really, really appreciated LJ's entire presentation. So thank you.
I'm curious, just having listened to all of y'all this time. Brad, I want to kick it over to you. What are maybe some of the biggest changes that you would like to see in our culture regarding mental health? And for everybody else, maybe that's substance use or disordered eating. But what are some of the biggest changes that you would like to see, and maybe that you wish you had when you were growing up, or when you were dealing with your specific struggle?
Yeah, I just wanted to, reiterate what Betsy said. LJ, I thought, your presentation and your perspective, I think, was really helpful in terms of how I was reflecting on how to actually answer this exact question. And one of the things that I would love to see a lot more of is movement away from binaries. what Betsy was just talking about, and LJ, what you were talking about in your presentation around like having to have like clear this or that answers to mental health challenges, to treatment protocols, to how we really think about what it means to be well. Those work for a lot of people, but who always gets left out, who always gets pushed aside, are the folks that are different, the folks that are not similar, the folks that are not white, the folks that are not cisgender, the folks that are not male, the folks that are the folks that are living in sort of this very beautiful, diverse majority, and we're really not treating the vast diaspora of like what this country actually is, by sticking to these binary options. And I think that there is, when I was growing up, when I was coming to terms with my sexuality, as I'm thinking about what it means to be a specific gender or not a gender at all, what it means to be in recovery, those things shouldn't have like 3 doors to go through. There should be thousands of doors. And of course, evidence-based practice is a thing, but evidence is not just like what's written in a scientific paper or a peer-reviewed journal. Evidence is what someone is experiencing in their own lives. And I really hope that the field in general takes a lot more of a look about like what their clients and what their patients are actually experiencing, and use that as evidence for how to treat them in the future. I think of the people that I love in our community that have been traumatized or dehumanized when they go and talk about very extremely valid and even common things that's part of their life experience, whether that be families that don't have a mother and father, folks who have a non-monogamous relationship, what it means to think about recovery outside of sort of like a 12-step program. Like, when we get tripped up on these things in a behavioral health setting, it doesn't allow us to sort of like step into the fullness of who we are as authentic people. And I think that's why a lot of people step away from the system, because they're not really being validated for who they can be entirely. And if you can't experience that in the room, like with someone who you're really sort of like ripping open your chest for, it's really hard to imagine yourself being your full authentic self out in the world in general, when that's supposed to be your safe space. And so I have a lot of hope, although we have a lot of work to do, that we can really take a lot of take the experiences of the folks who are needing care. And I know a lot of folks said this, like, ask the questions, like ask people what they need, and don't assume what they need or who they are or what the right answer is for them. That's supposed to be a collective journey. And I feel like if we prioritize that, and I think that getting more people in the system of providers of care that understand that and have felt that from other spaces, we will provide better care.
We appreciate that, Brad. Does anybody else, one of our panelists or LJ, would you like to answer that question as well?
Yeah, I mean, thinking about that question of, the things that I needed throughout my experience with my eating disorder, Brad, I love what you said about challenging binaries, and also challenging evidence-based practice. And I could talk for hours about that. But one thing that I was reflecting on is it is evidence-based standard practice within eating disorder treatment, at least from what I saw. I'm sure some people are doing it differently, but from what I saw, there's this model that we call body image comes last. And it's this idea that you treat someone's behaviors, you make sure that they are at a healthy and they're at a healthy weight, they're eating a nutritionally balanced diet, et cetera. but we don't touch or think about their experience, their lived experience in their body until maybe they've even left residential, which simply does not work for anyone, which is most people coming into care because they feel like they are not safe being embodied. It doesn't work when you're talking about trans clients who whose the function of their eating disorder is to change their body because they're not able to access gender affirming care, and that is the only way that they can change their body. This idea that one model fits just leaves so many people behind, and you find that's one of the reasons why we find people in this loop of cycling in and out of care is they get the care that they need, but it's not really hitting on the root issues. It's reinforcing binaries. It's reinforcing this very single idea of how they should recover. And then we're failing people. And then we're surprised when people return to treatment. So it's certainly that, I think that lens of erasing and really questioning binaries at every step of care, questioning assumptions, questioning evidence-based practice. That would have been so crucial to me at different points in my recovery and is really crucial to me now as I practice.
Thank you, LJ. I just want to make sure that anybody who would like to has one last opportunity to answer the same question. If there was something that you felt you needed in your own recovery or as you were growing up, what resources maybe you needed as well. If you don't have an answer, that's all right too. I just want to make sure I'm not cutting anybody off. All right, perfect. Well, thank you so much to all of our panelists and to LJ who have been with us this afternoon. Thank you to everybody who attended this and has joined our conversation. It's been really wonderful to share this experience with everybody. Seriously, this has been a great time for us to all learn together. And again, like I said, we're united in this front that we have this hope that things can get better, but we've got to put in the effort to make that happen. As we wrap up our program, we're going to hear one more time from Mental Health Colorado President and CEO Vincent Achity. Just one last time. Vincent, thank you for having us. We appreciate it.
Thank you, Jordan. And thank you so much, LJ and Katira and Brad and Christy and Betsy and Lindsay. What a great conversation. Many thanks also to all of you who've joined us, leaders, advocates, and allies. Mental Health Colorado, we work to raise your voice for healthier minds across the lifespan, and your experiences inform and guide our work. We all have roles to play in promoting greater health and well-being and in practicing loving harm reduction. There's 3 more things you can do today. First, you can give. For 70 years, Mental Health Colorado has worked to promote mental well-being, end discrimination, and ensure equitable access to care. It's life-changing, life-saving work. We've got a long ways to go, and your contribution makes it possible. You can give by visiting our website. Second, you can raise your voice by joining our Brainwave. The Brainwave is our statewide network of volunteer advocates. Brainwave members and their stories help dismantle barriers to care by sharing their lived experiences with lawmakers, the media, and community partners. And you can join the Brainwave by visiting our website as well. And then finally, today and every day, you can do something that's good for your own well-being. We all have many ways to take care of ourselves, from dancing like dorks while we cook, or playing soccer, or watching birds, or calling our friends and family just to say hello and be there for one another. We're inviting all Coloradans to think about the little ways you take care of yourselves and how those small moments add up to improved well-being for all of us. So where do you find joy, strength, or peace? Visit our website to share that with others. We hope you'll stay connected. Follow us on social media. Visit our website, subscribe to our newsletter. Many thanks again to Jordan and LJ and all our panelists, and to all of you. Take care. Hope you enjoy the rest of your day.
Thank you, Vincent.
Thank you.
Thanks, everyone. Have a great day.
Thanks.